Welcome everybody. It's a wonderful opportunity to have you here, old friends, new friends, and my former faculties. When we are talking about the front area, of course, treating a patient with a problem in the front area is always challenging. If you have to replace a single tooth in this area, it's challenging because we have to deal with the shape of the crown that we have to make. We have to deal with the dimension, we have to deal with the color. So it is always difficult. It's even more difficult when we have to deal with an implant and we have to change a tooth and put an implant inside of this area. So in a condition like this, of course, we have not just to think about teeth, but we have to think what is around our teeth. And especially, we have to think about the support of our teeth, which is the bone, and we have to think about our soft tissue support, which is the gingiva. And the bone and the soft tissue are representing, as it was previously explained by Dr. Tarno and Dr. Chu, and later by Dr. Salama, by the dual zone, which is a real entity. And this entity is responsible for our success or for our mistakes or for our failures. So, of course, we need anyway to have bone and soft tissue before to start. This young patient came to our office because of a fracture. She is a typical class 1. This tooth, the left central incisor, fracture, unfortunately. And we couldn't replace with another crown because the fracture was too deep. So we decided to extract the tooth. As you see here, there is already an aesthetical problem related to the fact that the tooth is not matching with the contralateral tooth. There is a discrepancy in dimension, shape, color. But anyway, it is typical class 1 and with a thin biotype. Talking about smile line, we can observe that the smile line of the patient is a medium smile line. And anyway, even in this medium smile line, this article reports that in 91% of the cases, even in a medium smile line, it's possible to see the papilla. So we have always to be concerned about the aesthetic of our front area, even in slow smile patients. So we decided at this point to replace this tooth with an implant. We extracted the tooth, and at the same time, we delivered a temporary crown. On the left side is the image of the tooth just inserted, and on the right side, you see the tooth that was already placed since 6-7 months. So at this point, we decided to go further, to take the impressions, and to remove the temporary, take impression, making the framework check-in, and after the framework check-in, we were able to finish the case in a really easy and straightforward way because we had all the ingredients for the success. We had the bone, we had the soft tissue. So it was a class 1, a typical easy case to manage in the office. For sure, it's more difficult to treat a patient instead when we are lacking of soft tissue and we are lacking of bone. In this case, for example, the patient was completely missing of the buccal plate, the tooth was loose, and this tooth, of course, the left central incisor, had to be replaced. The patient didn't want to go through big surgeries because, of course, in order to start a case like this, we have to augment the soft tissue and we have to augment also the bone. So this is a typical 3-class condition. So we decided, considering that the patient didn't want to go through a very complicated surgery, we decided to start with an alternative treatment. So we decided to start with an ortho treatment, and after several months, we were able to achieve a good result in terms of soft tissue and in terms of bone. So we decided to extract the tooth, to insert an implant, to insert a temporary abutment, and to deliver a crown. This crown, of course, inserted at the moment of the surgery, and the case was finished after that in a quite and simple way. This is the way it was finished, and the case is still stable and the way it is. What is more interesting, I would observe, instead, is the aspect of the bone. The bone was immensely growth, because growth like 4 millimeters. And this is also in accord to what the literature said, especially the recent article that Dr. Amato published last month on JOMI, and is really a wonderful article. Probably he will talk about that later. That is demonstrated that for every 10 millimeters of tooth extruded, we are going to gain between 6.5 to 7 millimeters of soft tissue and bone. And this is quite good. Anyway, this is the results that we had, and of course we were able to, at this point, to place an implant and achieve a good aesthetic. But of course, talking about aesthetic, we have also to talk about other aspects. For example, the mucogingival line, in this case, is stable from before to after. And this is also to observe also that the papillae were stable from before to after. The fact that mucogingival line was stable is because of the fact that the bottom of the sulcus in this patient is above the mucogingival line. So when we are able to stretch the tissue, we are not able to stretch the keratinized tissue, and we are not able to increase the level of the keratinized tissue as well. So our mucogingival line is stable. On the other side, there is something else to observe. We know that when every time we see a patient and we have to place an implant, we always evaluating the bone on the buccal side. And how are we able to evaluate the bone on the buccal side? Of course, with a probe, we can sound the bone. And we know that to place an implant in a safe way, we need 3 millimeters of sand in the bone and the mid-buccal facial area, and 4.5 to 5 millimeters interproximally. This is quite clear, but how do we know, how is the relationship between the level of the root and the buccal and the palatal bone? Recently, Khan published this very interesting article, and he classified 4 conditions. 4 different conditions are related to the relation existing between the root, the buccal bone, and the palatal bone. He classified 4 different classes. On class 1, the root is moved toward the buccal bone, so we don't have bone on the buccal side, but on the other side, we don't need to place an implant in a safe way in a case like this, because we need the bone on the palatal side. On class 2, we have the root just in the middle of the buccal bone and the palatal bone, so we have both sides of bone. And this is also a good condition. Instead, class 3 and class 4 are representing not good conditions for immediate implant placement, because the root is moved toward the palatal bone and there is no bone on this side. So ideally, we are able to say that class 1 and class 2 are representing the 2 ideal conditions, but we are not able to make a diagnosis without making a CT scan before. For this reason, we have also to analyze how is the percentage statistically of these conditions, because class 1 and class 2 altogether are representing the majority of the population, almost 80%. Instead, class 3 and class 4 are representing a minority, but if you are extracting a tooth and if you are placing an implant in class 3 and class 4 without knowing that this is a lacking of bone on the buccal side, on the palatal side, you are in big trouble. In this case, the patient came to our office. She is a young businesswoman, She is, of course, aesthetically challenged. She doesn't smile anymore. She has an early aggressive periodontitis, and she used to see many dentists. Every dentist did something on her, especially on the first quadrant. They did every kind of procedures. Osteosurgeries, bone grafting, connective tissue grafting, any kind of mucogingival surgery, and laser therapy as well. The result is this. But on the other side, let's take a look to the X-ray of this case. On the left side, this is the situation, and on the right side, the situation is the following. It's even worse. Let's see the X-rays. Okay. So at this point, we were quite in doubt what to do. Anyway, we did as first evaluation of the microbiological situation of this patient. So we did a status, a bacterial status of this patient, and we analyzed what happened before and what was the situation at this moment when the patient came to our office, which was 2010. The patient had already evaluation of the microbiological status before, done in 2006, so we were able to compare what she had in 2006 to our moment. So we started, of course, with stabilizing the perio health of the patient. We started a perio therapy that was performed by my colleague and my partner, Dr. Moreno, also with the help of chemotherapeutics. And at the end of the situation, the situation was quite stable. The tissue were healthy, and we were able to start thinking what to do with the treatment plan. On the other side, the good aspect was that the smile line of the patient was quite low. So starting from this point, we started thinking what was the ideal condition. And as we saw before, everybody can think differently how to rehabilitate properly this patient. I don't say that my treatment plan is perfect or is ideal. Probably under my hands, in my hands is good. In the other hands, on the end of somebody else, probably is different. And anybody of you would be able to interpret this treatment plan in a different way. But the patient didn't want to go over a very complicated and difficult treatment. So we decided to start an ortho treatment in order to increase the soft tissue and the bone as well. But of course, the patient was quite afraid about aesthetic, so we didn't want to jeopardize the treatment plan. So we sent her to an orthodontist who is a very good orthodontist, and this guy was able to perform a lingual orthodontics. Of course, the lingual orthodontics is much more difficult, as everybody can imagine. So the treatment plan, the ortho treatment lasts quite long, and at the end of the treatment, we were able to arrive to this point when the tissue were stabilized and the tissue were healthy. So we took again X-rays. The patient at this moment was finished the treatment plan, the ortho treatment, and we stabilized on temporary. This is the situation at the moment with the temporaries. And we are planning some minor adjustments. She is in a perfect oral health. She had a good oral hygiene, and she has especially very good motivation. And this treatment plan was probably ideal, and we were able to perform just because she had a very good cooperation and she was very motivated. And this kind of treatment was just possible because of that. So we moved from this point to this point when the patient is still the temporary. What is the future? The future, as probably Dr. Mao was predicting this morning, could be a very bright future. We will be able to place stem cells. It will be able, maybe in 10 years, 20 years, to regenerate the bone and soft tissue, maybe with an injection. Hopefully, we'll be able to be here and to see this bright. Thank you for listening to this presentation and for being connected with Dental XP.